Good morning. My name is Alex Pacheco. I'm from Guadalajara, Jalisco, Mexico. I'd like to thank Dr. Ulises Rogel and the team of Latin American Heart Society Committee for the invitation for this joint session with American nurse. Today, I'm going to talk about catheter ablation and left atrial appendage occlusion for atrial fibrillation, a combined in a single procedure. The recent released ESC guidelines for diagnosis and management of atrial fibrillation put the treatment of atrial fibrillation in 3 topics, A, B, C. As you can see, A is for anticoagulation and stroke, and avoiding stroke. B for better symptom control, and C, comorbidities, cardiovascular risk factor management. In this case, we're going to talk about mostly the A that is anticoagulation and other techniques to avoiding stroke. The ideal therapy today is the anticoagulation for thrombosis or thromboembolism prevention or stroke prevention. The DOACs are the preferred therapy because they are easier to use. They have a reduction in mortality driven by a substantially lower risk of intracoronal hemorrhage or fatal bleeding. So if we stay with this idea or ideal therapy, we can stop just right here and go to the next talk. But sometimes you have to offer left atrial appendage occlusion to mainly patients that have absolute contraindications for oral anticoagulation or that have a high risk of bleeding using these DOACs that outweighs their proven advantage in stroke prevention. So the pathophysiology of thrombosis formation in atrial fibrillation depends on the triad of Virchow. We're having some prothrombotic state because of the big inflammation during atrial fibrillation. We have also the endothelial denudation with diminishing contractility of the atrium that's going to give some estasis and give the proper substrate to thrombus formation. The left atrial appendage is also a vulnerable site, not only because it can be remodeling with bigger or larger LA size, but also there is different morphologies in the left atrial appendage that can bring from lower to bigger risk of thrombosis, like windsock morphology, cactus morphology, or cauliflower morphology, and increasing risk. So it's logical to think that putting a device that can occlude the left atrial appendage can also have a good results in long term. But what will be the effects of LA occlusion? First of all, we can have some downregulation of RAS, and that's because of downregulation also for the brain and atrial natriuretic peptides. But also we can prevent thromboembolic stroke. We can reduce arrhythmias because we have, and we know that the left atrial appendage is a source, 20% of extrapulmonary triggers for atrial fibrillation. And we also going to improve the left atrial reservoir and cardiac function, almost because of the downregulation of neuromoral secretion in the left atrial appendage. But the occluder, what's going to do? The occluder is going to regulate only just one, just the prevention of thromboembolic stroke. The other one are not touched by this. At least not the occluders. The ligation perhaps can downregulate a little bit more the RAS and reduce also the arrhythmias. This is an interesting study very recently published in JACC, where they randomly assigned patients with non-valvular atrial fibrillation under oral articulation history and history of bleeding, recurrent intervention, cardiobolic event while taking OACs, and the CHAS-VASc score are 3 or more, and it has bed more than 2. So it's not typical patients, it's more high-risk patient. And they do this non-inferiority study trial where they demonstrate that the occluder was non-inferior to the DUOC, mostly apixaban was the DUOC used, and the two occluders were the amulet and the Watchman device. What are the indications for LA occlusion? First of all, the patient has to receive a good explanation for the benefits to have a good anticoagulation. And the occluder can be placed in this patient that refuse anticoagulation despite this explanation, but always prefer the anticoagulation. The absolute contraindication for patient contraindication for anticoagulation is also an indication for LA occluders, but also for this patient that can have an elevated bleeding risk during long-term anticoagulation. Stroke and embolism under good therapy of oral anticoagulation can also be an indication for LA occluder. But if the patient have also non-compliance in the therapy of anticoagulants, it also can be an indication to put an occluder in the appendage. The thing that we should not do is say to the patients that the LA occluder is a simple and equally effective treatment alternative, because that is not true. Other indications for LA occlusions are patients with oral anticoagulation not efficient. It means that have some stroke with the therapy, even with the therapy. This patient with electrically isolated left atrial appendage post-catheter ablation, and combination of atrial fibrillation ablation and LLA occluder implantation, and those patients with left atrial occluder closure for primary prevention. In this slide, we can resume all the indications for LA occluder. As you can see, always favors of oral anticoagulation and DUOCs on the first line in case of non-valvular atrial fibrillation, but you can have the elevated bleeding risk, this patient with inefficient oral anticoagulation, electrical isolated left atrial ablation, left atrial appendage, sorry, and a patient unwilling, unable to take oral anticoagulation. And of course, the absolute contraindication for oral anticoagulation for a patient to occlude it. So, what guidelines recommend is continue oral anticoagulation based on the CHAS-VASc score and not on the perceived outcome of ablation. That means that continuing anticoagulation in the patient with true non-recurrence, it could be patient with needless lifelong strategy of oral anticoagulation. And this also associated with compound risk of bleeding that increases with age. So thinking about AF ablation and left atrial appendage closure is a very attractive given that the access to the left atrium is already established. In this prospective observational trial with 62 patients with atrial fibrillation ablation combined with left atrial appendage closure, as we can see at the beginning of the study, before the implantation of the device, 80% of the patients were under anticoagulation. And with a time of 3 months, and at the end of the follow-up, most of the patients were without any anticoagulant or only with antiplatelet therapy for prevention of stroke. And they report in this study only 3 ischemic strokes with an annual stroke risk of 1.7, that is lower than expected of 6.5%. In these 2 larger registries of multi-center registries in Europe, Middle East, Russia, Asia, Australia, we have 142 patients, and we can see also that only 8% of the patients continue under anticoagulation, and the observed major bleeding was lower than expected because calculated by the HASBED, or also the observed stroke in this cohort was also lower than the expected based on the CHASVA score during the observational studies. In this systematic review and meta-analysis, where they compare all the trials with atrial fibrillation ablation and left atrial appendage occlusion, they conclude that the single procedure with catheter ablation and left atrial appendage occlusion is in atrial fibrillation is a feasible strategy with significant efficacy and safety. We know that the left atrial appendage is a source of extrapulmonary triggers for atrial fibrillation. And in this meta-analysis, they compare the exclusion of the left atrial appendage with LARAT device or surgical excision or electrical isolation with radiofrequency ablation. And they found that atrial fibrillation and atrial tachycardia recurrences were lower in the left atrial appendage isolation or exclusion. But the thromboembolism was also a little bit higher, even though it wasn't significant. After that, we know that there is increasing risk in thrombosis after electrical isolation of the left atrial appendage. So in this study, DiBiase et al. Compare this patient after ablation and the electrical isolation of the left atrial appendage, and they do a transvaginal echocardiography after 6 months of ablation. If there was a good velocity, so a normal function of the left atrial appendage, they take off all the anticoagulants with a good results with no thromboembolic events. But if the velocity was low, there was two types of patients: those that continue anticoagulation and those that taken off the anticoagulation. Those with anticoagulation had 1.7% of thromboembolic events, but with a suboptimal anticoagulation. And with the patient without the anticoagulation, there was a 16.7% of thromboembolic events. Those patients go to LLA closure, and in a long review after that, they only have a thromboembolic event of 1.19%, with 98% of discontinuing oral anticoagulation. So in this study, they demonstrate that atrial fibrillation ablation can be done with left atrial appendage occlusion and electrical isolation, whatever technology you can use, if cryo or radiofrequency ablation. This was with long-standing persistent atrial fibrillation patients with 94% freedom of atrial fibrillation, atrial tachycardia at 1 year, with no thromboembolism reported, and only 3 thrombus formation due to oral anticoagulation stopped too early. The issue here is to think that the edema and inflammation that can develop resulting from the tissue injury can bring difficulties to choose a device to occlude the left atrial appendage. So the measurements have to to be done before the ablation, or if it's in the right moment with an angiography to have more precise size of the appendage. So take-home messages. The indication of left atrial appendage occlusion in high-risk patients should follow the same risk-benefit analysis in patients without AF ablation. The concomitant catheter ablation for atrial fibrillation and mechanical left atrial appendage closure is feasible, safe, with selected patients with non-valvular atrial fibrillation and high-risk stroke. There is issues, limitations like reimbursement, and no strong evidence. Thank you.